The liver, second biggest organ in the body, multi-shaped, normality and pathology in fluent transition, a topic too vast for claiming completeness. Therefore, we point out to older non-electronic literature, for example, Günther Schmidt et al., sonographical differential diagnosis, and as a significant considered choice of examples as normals figures 1 to 6, we have chosen some special cases. And third, measurement of the liver is doubtful. There are no normal values. In detail, figure 2 is a normal transverse section with the pancreas, duodenal bulb, and left liver lobe. Figure 3 is a TS normal with the vascularization of left liver lobe segments 2 and 3. And figure 4 is a subcostal section normal with right liver lobe and diaphragma, whereas figure 5 is another SCS normal as well with a mirror artifact above air-filled right lung. Figure 6 is a frequent pathology right heart failure with distended veins. We come back to that at the end of the contribution. And another incidental is in finding 7. Anyhow, we also follow the accepted discrimination in A, diffuse changes in reflexivity, and in B, focal lesions. Please note, relativity in reflexibility must always be considered, and it is noteworthy that high percentage, up to 15% of the FLs, is not depicted at all, since there simply is no difference to the reflexivity of adjacent tissue. Another example of enhanced liver echogenicity is here in figure 9. Please compare to kidney echogenicity. Number 10 is an example for a liver focal lesion. It is simply another cyst. Sharp margins of the organ include normal volume. Pathology in here will be discussed later. Rounded margins of the organ indicate an increase in volume. This in figure 13 was really dramatic, an acute liver failure leading to patient's death. Following BCG vaccination, this diagnosis in figure 14 was based on histology, as well as here in case 15. Back to configuration, liver cirrhosis can lead to bizarre deconfigurations as here in figure 16. Carefully regarding all details in figure 17 allows the diagnosis of a decompensated micronodular liver cirrhosis. Please note liver stiffness. Segment 1 needs special attention in liver cirrhosis like in figure 18. It is usually enhanced and deconfigurated. Like here in figure 19, however, volume and spontaneous elastography are normal, as well as heartbeats are transmitted normally to left lever lobe in figure 20. Heartbeats push the whole of consistently augmented left lever lobe. Back to FS again. In figure 22, there are FLs in grayscale only, not so in an additional contrast study. So in the end, they were classed as regenerative nodules only, which became true in the further course of years of observation of this patient. Years prior to this finding, in figure 23, an operated mamma carcinoma was found. With hemangiomata, like in figure 24, smaller ones up to 1 centimeter are filled with capillaries, and bigger ones exceeding 1 centimeter or so with lacunary spaces, all of them being slowly filled and perfused from periphery. This cyst in 25 was found subsequently to a laparoscopic intervention. This echinococcus is rare in Europeans, but it's posing a real problem for Mediterraneans. A better nutritioned, oxygenated liver area is, however, of none importance, like here in figure 27. As well as this segmental area of better nutrition is visible by less echogenicity in figure 28. Sudden inspiration in the course of PTSD led to this rare injury, spontaneous healing. Like in figure 30, months after Whipple's operation, this had to be observed as a new finding, as it is very often the case. This typical FNH could be found in a perfusion study in figure 31. In figure 32, hidden metastasis as it is nearly echo-like to surrounding. In 33, you find a vividly perfused lung tumor, and in figure 34, a huge multiloculated post-operative liver abscess. This other abscess had to be punctured repeatedly. Even this minor abscess in figure 36 target needed intervention. And here in figure 37, once more an easily overlooked metastasis is demonstrated. Metastasis obvious in perfusion study only in figure 38. And in figure 39, clinical data again proved the systemic impact of this abscess here in figure 39, which has gas-producing elements. Despite these multiple cysts, in figure 40, the patient was free of symptoms. The prime tumor in this case, in figure 41, was located near the duodenum, and in this case, 42, the primary tumor was from the urethra. This hematoma in figure 43 was punctured for both diagnostic and therapeutic purposes. This tumor in figure 44 had to be found as well in the liver. And in figure 45, never do a fine needle puncture because there is no covering tissue. You must have a covered path. In figure 46, you find a metastatic ovarian cancer. And in figure 47, this newly arisen tumor in a chronic alcohol addict is suspicious of an HCC. And even the more in this case here in 48 with affection of the portal veins. And here in this third case in figure 49 as well. Figure 50, however, shows an HCC 2. It was maldiagnosed first as chondropathia. A percutaneous ethanol injection, PEI, was carried out without any problems in 51. The result of contrast control after 3 months remained somewhat doubtful. This gallbladder carcinoma in 53 already invaded the liver. A malignancy in figure 54 was leading to this extraordinary biliary congestion, compared to case 28 with no biliary congestion. In case 55, both types of focal lesion are found together, the less prominent being the more important. At the first glance in figure 56, this looks like an adrenal tumor, but contrast study reveals true nature of the mass. A typical HCC in figure 57. In figure 58, the disturbance of the echogenicity over decades was unclear despite repeated puncture and histology. Enzymes were slightly elevated. In figure 59, inverse flow in portal vein is a sign of cirrhosis. The liver as a sponge composed by 5 vessel systems, including the lymphatics, is demonstrated in 60. This liver as a sponge is in both modalities demonstrated in figure 61, and we remember the quotation of Mr. Bianchi, who said any liver cirrhosis is certain of an individual. A thrombus in cava, inferior in figure 62. Once more in 63, this is typical for an HCC. Normal, slightly atherosclerotic liver hilum as reference in figure 64. And in figure 65, you find Usler's participation in liver disease. The already shown case under case 8 with congestive heart disease would not undergo puncture but cardiac further evaluation. A typical extrahepatic PSC manifestation is here in case number 67. PSC is also found in intrahilar bile ducts like in figure 68. This cirrhosis in 69 developed in PBC, lasting for decades. No harm was known to liver from an extensive EST decades before in cases 70. This disturbance in vascular architecture is a landmark in liver cirrhosis in figure 71. This in figure 72 has to be considered as a serious sign, usually announcing abdominal abscesses. Obviously, not necessarily all bile duct stones always are symptomatic, like here in figure 73. In figure 74, it is so to say a triple shotgun mimicked with acoustic mini windows for artery and bile duct branches. In figure 75, sludge surrounds the obturated biliary stent. The seldom feature of transcutaneously depictable varices with the nowadays equipment is seen in this patient in number 676. No symptoms in 77, but good to know before an operation about this varices, and it is accessible by ultrasound only. This unique case of a bleeding after FNP was self-limiting, a complication of FNP anyhow.